All right, it's now live.
All right, and I'm going to turn my video off and turn it over to Ricky Stevenson. Ricky Stevenson is one of our officers for the Developing Professionals Forum. The Developing Professionals Forum officers, as well as the Ascending Professional Forum officers, are who we have to give credit to that put these on. So without further ado, here's Ricky.
Good evening, everyone. Glad you guys are able to come in and participate with us, panelists and listeners. So this is our first Ask Me Anything of the year, and this will be on Doctorate in Clinical Laboratory Science, put together by the Ascending and Developing Professionals Forum. As she was saying, the officers all put it together. This is how it should be structured. I'll just tell you guys about how AMAs go and our goals for that. Then I'll introduce our panelists, have them say a few things about themselves, and then we'll open the floor to questions. So if at any time, if you guys aren't able to see anything or if the screens haven't shown for you, let me know. So Ask Me Anything were created by ASCLS in order to provide our members, as well as even if you aren't a member, you're able to join these about different parts of the clinical laboratory science field by our panelists' personal experiences. This specific AMA is about the DCLS, which is a Doctorate of Clinical Laboratory Science. There's less than 10 programs in the US. So you would guess that selection for these are very scarce, and luckily we're able to get people that are able to speak about these programs. So thank you for everyone who were able to join us. Next, we will introduce the panelists. We have Dr. Lindsey Davenport-Landry. If you guys want to say hello or whatever, I'll have you introduce yourself after, but I can just read off the names first. We have Dr. Regina Wulff, Kathryn Golab, and Renee Hodgkins. So any order you guys want to go, I don't have any specific. Whoever's here can pop in, and then you guys can just take turns.
I guess I'll start. Dr. Davenport-Landry isn't on the call yet, or I haven't seen her drop in. But hi, my name is Kathryn Golab. I am the hematology technical specialist at Wisconsin Diagnostic Laboratories in Milwaukee, Wisconsin. And I am also a third-year DCLS student with Rutgers School of Health Professions.
Renee?
Hey, it's Lindsey. Sorry I was late.
Hey!
I'm failing at communication tonight, and I didn't realize it was 6 o'clock.
Renee, you want to go ahead?
Sure. Hi, I'm Dr. Renee Hodgkins. I am a DCLS program director at the University of Kansas Medical Center. I have served on the DCLS Oversight Committee for ASCLS since 2015, and I was the chair for 5 years. This gave me an opportunity to learn a lot about the history and the origin story of the DCLS. I currently serve as the vice chair and the discipline lead person for the Doctoral Review Committee for NACLS, our accrediting body. And the DCLS program is really meant to be training us to be able to deliver the right test for the right patient at the right time. Similar in path to the clinical pharmacist, the DCLS was born out of the increase in laboratory testing and the need to help the healthcare team choose the right test and evaluate the interpretation in the context of the patient. I'm happy to be here. Thank you for inviting me to be part of the panel.
Hi, I'm Regina Wulff, and I'm a recent DCLS grad from the Rutgers University program. I currently work at New York Presbyterian Hospital at the Weill Cornell campus in Manhattan. And I just started in November and I'm working part-time. I'm actually going to be going on maternity leave in like 2 days. So I'll come back in February and I'll be able to make more of a dent in my role, but happy to be here. Thank you.
Dr. Lindsey, you want to say anything?
Yeah, my name is Lindsey Davenport-Landry. I graduated with Regina from Rutgers this last year. I am a clinical, I do rounds at the VA in Iowa City, as well as the current chief medical technologist for the Department of Pathology. I also teach at Kirkwood Medical Center and have served on the DCLS Oversight Board. My current position with ASCLS, though, is as Region 6 Director.
Thank you all for introducing yourselves. For anybody who's popping in late, you will get to know more about them as we go through the questions. You also will have your ability to ask your own questions. So for questions, we'll pop them in the chat, or you just raise your hand and I can pick on you. So you have however you want to do that.
Ricky, why don't you go ahead and stop your share so that we can see all the panelists so people can see everyone.
Okay. All right, should be out. Andrea?
Yep, we can see everyone. So
okay. All right.
Go ahead with some of your questions until we get some in the chat.
Okay. Just a second. So I will put out a question, I guess, for the students, the current students. What made you want to pursue doctorate program in CLS?
I guess, everybody has a different story about how they got into wanting to be a DCLS, but my story came about, I got to meet Dr. Brandy Gunslis, who was the first DCLS back in 2018 at the National ASCLS meeting. And she did a presentation that year on her residency program. So she talked about different interventions that she did, different cases that she worked on while she was a DCLS student or a DCLS resident at her hospital in Augusta, Georgia. And I was listening to her stories and I'm like, I completely agree with all of this. Like, I understand exactly how she was feeling, where she would run into these situations where somebody was calling into the laboratory looking for answers about laboratory tests or asking, what does this laboratory test mean? Or how does this test work? And realizing that there needs to be more communication between the lab and just general practitioners of medicine to, explain the connection between the laboratory and clinical diagnosis and how it all correlates with one another. And, I had this instance not long after we met and were talking where I was working in the laboratory and we had a patient come into our hospital who had tested positive for malaria. They had Plasmodium falciparum, and they had a scheduled dosing time for when they needed to treat their patient. And they did not, unfortunately, realize that when we do malarial quantitations, it's an entirely manual process. They thought that it was something that they could run on, that we ran on an analyzer and we can get them a result. So they would send down a sample, unfortunately, not as fever spiked like we would want as, laboratory professionals. They would send it down timed like 1 hour prior to when they wanted to change the dosing of this patient's medication. And in doing so, that test takes us 3 hours on a good day to complete. So they were calling, complaining that it was taking forever for them to get their results. Why weren't we done sooner? And I had the opportunity to take the call from one of our client services representatives at my hospital. And I said, let me just talk to them. Let me hear what they have to say. And after a nice rant, I let the infectious disease doctor, kind of get it out of his system. And I explained to him, it's like, well, this is a manual process. I have to manually stain my slides. I have to manually count 1,000 red cells and then do the math to see what the percent parasite infection is. and then you can get your result. And he had absolutely no idea that that was exactly how I did it. And, he's just like, okay, well, how long is it going to take for me to get results now? And I'm like, as soon as I get off the phone with you, I will be done in 20 minutes. So it was, he kind of had this eye-opening moment of just like, oh, so that's how this works. And from that point on, after having, this conversation with this doctor, if they were changing the dose, if they wanted to dose the patient at noon, instead of sending the sample down at 11, like they had been, we had actually started getting the sample at 8, 9 o'clock in the morning, giving us the 3 to 4 hours we needed to do this manual test. So by the time they rounded on the patient at noon and made the medication change, they had results in the chart. And having just that, taking the time to sit down and have that one conversation, I'm just like, oh, what other impacts could I have? How else could I change this and, make an impact? And that's what really kind of pushed me to, put my application in and apply to the DCLS program. And I'm just happy to be here. As anyone who's been through the program can say, it's a long haul and it's hard. But I am genuinely appreciative of being able to put in the work and being able to make this change in the health profession.
Thank you, Kathryn. That was a really good answer too, though. Very in-depth. Renee, if you want to add on to that or answer one of the other questions, I have a few questions in the chat, but if you want to answer that one, go ahead.
As far as motivation to pursue a DCLS,
yes, ma'am.
What I hear from my students is that they want to take their career to the next step. They know all this information and they want to help with patient care in a way that we can't do by being in the laboratory. We need that external communication with the healthcare team, being part of that team, being able to do the things like, hey, if you wait until 11 o'clock to draw a test where you want to dose somebody with a medication at noon, that doesn't make any sense. We need that test earlier. But being there at the patient's, not at the patient's bedside, but at the clinician's side to help guide some of those decisions in the moment and help with patient care is the bottom drive for most of the students that I've had the chance to speak with. I don't know, Lindsey, Regina, do you have your origin story?
Mine evolved. So when I was a beginning student, I really didn't know exactly where the DCLS was going to land me. I kind of had my sights on director level. I was willing to kind of see what jobs would be offered to me once I graduated. So I think the most effective way I can kind of reach out to this group right now is to explain what I'm doing right now, because it's not something that I had imagined when I first started the program. So I work at New York Presbyterian Hospital, which is an academic medical system that has 8 hospitals in New York City. And they don't have a lab stewardship program. And what lab stewardship is like making sure that the right tests are being ordered without waste, making sure that new tests are being brought on and old tests are being phased out, making sure that we're able to change operations so that we can accommodate staff shortages, supply shortages, things like that. And so it's actually a much broader position than I ever imagined before. And it kind of oversees all of the hospitals. I'm working with a lot of like senior pathologists and senior clinical medical directors who either are directly patient facing. I work with IT, and we're trying to find solutions to a lot of the laboratory problems. So for instance, we've been working on COVID ever since that started, just with supply chain issues and staffing issues with that. And that's just one minor thing. The other thing is that interfacing with like Epic, which is our electronic health record, with the LIS as far as new tests go, even creating a new system for when clinicians want a new test. What is the, like, organizationally, how are we going to like kind of like, who does it go to? What does that person do? Like, we're just trying to structure an organization, chart even, just to have a process in place so that these things can be more streamlined in the future. These things have kind of sort of existed before, but it's been haphazard. And honestly, all the clinicians, all the pathologists, all the laboratorians are super busy, and nobody has time to kind of dedicate their time just solely on these projects. So that's kind of where the DCLS fits in my particular role. So I'm able to kind of like push these projects forward, connect the right people to the right solutions, and then bring them up to, higher up into the organizations to get approvals and, potentially funding to like make some of our future goals kind of get realized as well. So that's what I have to share.
Thank you for sharing that.
Oh, go ahead.
You can go.
I'll say a bit of my origin story is I'm a blood banker by background. I was in the blood bank and hematology for a long time. And CP, we have pathology residents. However, they're only on service for about 4 weeks at a time at our facility. So they don't get to know a lot of the policies and procedures. So as a blood bank supervisor, I would often get interfaced with the faculty in surgery or HEMOC or wherever. And I was doing kind of the liaison between the pathologist and the staff members. So with blood bank especially, you have to have a lot of dialogue to ensure you're using the right products or doing the right thing. And so I was already doing that a lot with transfusion medicine. And one thing I started doing was actually rounding on patients before I started the DCLS, just going up and kind of talking to the providers, being like, I know this guy is already really low. We're going to have this surgery. It's a big risk. Like, what can we do beforehand to make sure that we're ready? And some of those conversations kind of got me excited about having the clinical background to really propel myself into doing that for all the laboratory tests, not just kind of my background specialty. I never felt very confident talking about microbiology or molecular before, but the curriculum has really helped with that, kind of giving me the confidence to do that. But I have landed in a manager's role for the last 5 years. And that kind of gave me a different perspective as well on how the laboratory is run, from not just the pathologist side or the clinical side, but also the management side. So now I see what the providers also have to deal with when they, in regards to like residency requirements, ensuring that their fellows have enough time to document things. So that's kind of my origin story. Is I started with blood bank and I really liked that part, and just continuing to learn brought me to the DCLS.
Those are pretty solid answers. So I have a few questions in the chat. Thank you for whoever, I saw someone was answering them. Renee, thank you for that. I wanted to highlight one of these. Let me find it really quick. Someone wanted to know, Blake Maloney wanted to know if the relationship with pathologists, do they view this as an encroachment on their practice? If anybody has any insight on this or experience with it.
So just from my perspective, and this is just my hospital, I cannot speak for other sites, but my hospital is affiliated with the Medical College of Wisconsin. And our chair of pathology is a hematopathologist. And he is so excited to bring a DCLS on. He honestly wants more than one DCLS in practice because we're a 1,000 bed hospital, not just our hospital, not including others in the system. But he is very utilization oriented, and they don't have time in the size hospital that we are to go through and make sure that physicians are appropriately utilizing laboratory resources. We have some interventions where the pathology residents work on screening send-out tests and making sure the appropriate send-out tests are ordered. But when it comes to just day-to-day utilization, they don't have the time to make sure that doctors are not inappropriately utilizing the resources. So by bringing on a DCLS, there's the opportunity for them to take some of that workload that would potentially be on their plates off so they can focus on the anatomic or clinical case workload that they have. And we can take over some of the running of the utilization and stewardship programs at the hospital. So we'd be able to sit in some of their places and have them back us up if we need to. But my hospital is very receptive to having a DCLS because we want to bring in a lot of utilization programs, and having a DCLS there to run them is a huge benefit because then they can focus on the casework and we can focus on the clinical workload.
I've had
Does anybody
positive
have-
experiences with pathologists. If the pathologist understands the DCLS kind of program and program goals, usually they're very receptive to it. It's the ones who maybe don't know much about it. They just need a little education. And once you can kind of tell them what you can do for them, they're very excited.
There's one thing with that, to piggyback up what Regina's saying, is a lot of pathologists were originally scared by another doctorate being in the clinical laboratory. They're like, no, we do our jobs just fine. They do a great job, but we're not taking their job. We're filling in the gap between the provider on the floor and the pathologist, who and a lot of times is anatomic in nature. And a lot of hospitals actually don't have a clinical pathologist. So we help fill the gap in that knowledge. And when we need help or have questions, there's still a pathologist there to ask, or you have colleagues that may know the answer. And so you have to just reassure them, we're not here to take your job or to kick you out of the marketplace. We're here to be your partner.
Yeah, I think there's always that kind of gut check, that gut reaction when a new profession hits the scene, that somebody's trying to take over your work or trying to take over your role. And while there's a lot of role overlap, they're very, very distinct and very, very different areas. Most of the time we try to express it as this is to help, as Lindsey said, that gap. There's a huge gap in our laboratories, all that QA work that we want to get done, but we just don't have the hands to get it done. We don't have the people who are trained who can get it done. The DCLS helps fill that role. They're trained in research and how to conduct validation and how to serve as that bridge. And I think as long as we make that distinction different and help explain it, it's just getting in front of an audience to listen to that explanation. There has been resistance. I'm not going to say that there hasn't been resistance over the years, but once you explain the difference, it gets received really well.
Glad we were able to have some positive and I guess some resistance or negatives on that feedback. I have another question from Kasimbo Peter. Is there any possibility for student exchange, and which university allows students exchange? As far as you guys know, I guess, with the programs you're in or any of the programs you know of.
I was gonna say, Renee, this sounds like a question for you.
That's a really great question. I need a little bit more information about what you mean by student exchange. I know there was another question in the chat that I haven't gotten a chance to address about international students. And one thing about international students is so right now there's 3 programs nationwide: Rutgers University in New Jersey, University of Texas Medical Branch in Galveston, and then my program at the University of Kansas Medical Center. So those are the three that I'm at least aware of, that NACLS is aware of. If there are more, then I'm not privy to that information. There is a difference between a DCLS and a PhD in biomedical sciences. There is also an MLSD, and that's an international, I believe, in Nigeria. There's a doctorate in medical laboratory science, and the designation is MLSD. In the United States, we use the DCLS for that clinical doctorate in medical laboratory science. A distinction is that the DCLS is an advanced practice doctorate. What does that mean? That means it's not the first certification or degree for practice in medical laboratory science. It is an advanced practice. You have to have your ASCP certification as a medical laboratory scientist to become a DCLS. For a PhD, there are differences in training between a clinical doctorate and a PhD. A clinical doctorate, the focus is on the clinical component. So when you look at our transcripts, less than 30% of our credit hours are research oriented. They're clinically oriented. All three programs have a clinical residency component or a clinical experience component that's required as part of the degree, and that happens prior to graduation. For Rutgers and for KUMC, we have a year-long clinical residency component where you're placed at an affiliate and you spend 46 to 48 weeks working as a DCLS or training as a DCLS in a clinical setting. UTMB uses a different structure. They have their students go to Galveston 4 weeks every year and complete the clinical experience down in Galveston. So that is that clinical component of the clinical doctorate. If you get a PhD, you have a really high percentage of your credits are research related, and you're doing a full dissertation. With a clinical doctorate, you might be doing a capstone project where you're doing a QA/QI project, or maybe even some basic science projects would qualify for a capstone for a DCLS. A PhD is going to have that typical dissertation component where you have the 3 publishable papers, or you have a more traditional dissertation format. Are they the same? No. There are programs that have tried to present, or I should say universities that have tried to present the DCLS to their institutions and have found that they cannot bring on a clinical doctorate. I do imagine someday in the future we'll see a PhD with a clinical doctorate type background, but currently there's not.
Elinette, so to answer part of your question that is piggybacking off of what Renee just said, is that they do offer online programs. I believe all 3 of us have online for the majority of the teaching. And then the clinical practice, I think everyone has had to do that at a medical institution. Mm-hmm. I don't know if there's anything that's at a smaller clinic sized place. I mean, eventually I think that DCLSs will have a big role in like larger clinics with laboratories. At this point, I don't think we're there yet because we're really trying to ensure that they see more broad and get everything kind of covered before they go back and have like a more specialized area to just cover.
I was gonna say, I know my friend Biz, she's a year ahead of me in the Rutgers program. She just signed her contract. I think it's at her hospital where she currently works. So I know she works at a smaller hospital. So a majority of the time though, when you are looking for a residency site, it needs to be at an advanced academic medical center. So there needs to be some amount of at least medical education happening at your facility where they're doing the residency site. You know, my hospital is affiliated with the Medical College of Wisconsin. Dr. Davenport's hospital is associated with the Medical College as well. Same with Dr. Wulff's. So they're same with Dr. Gunsel's. All the hospitals that I know of at this point have been associated with a medical college. So that is something to keep in mind. We are branching out around the country, starting new affiliation sites around the country. So hopefully by the time you get to a program, if you're thinking about this, that this might be something you want to do, we'll have more clinical sites available across the country. I know a lot of them are swung heavily East Coast right now, but that's because Rutgers was the first and everything is on the East Coast, but we're moving west. I know my hospital and Rutgers are just starting their contract negotiations, so mine will be a Midwest hub along with Dr. Davenport. So
yeah, I can talk about clinical placements a little bit too. I'm in the process of setting up clinical placements for a few of my students, and the thing that I tell them is that as long as your institution can cover all the points we need addressed in your clinical residency, I'm willing to work to try to get all of those competencies met. It doesn't mean that it's foolproof and that it's going to go through, but if you're not able to do it at your clinic, if you kind of have two places that you can go and balance it out, as long as you're able to hit the competency marks as part of that clinical residency, that is what is the most important component of setting up the clinical residency. I know that we've been working with VAs, VA medical centers. We actually have been talking with Quest about setting up a clinical residency with them, getting kind of creative with that clinical placement component, doing that clinical rounding, which is the hardest part of the clinical residency when you're building it out, is making sure that that clinical rounding piece is there. Back to the international question, because the courses for all three programs are online, if you're in the United States on a visa, you would not be able to take the DCLS program. So that's something to keep in mind. If you're in the United States on a visa, there's a limit of how many online courses you're allowed to take on a visa. If you've been in the United States and you've worked and hit that 2 years of work experience as an MLS in the United States and you're currently in another country, you can do the online component. I know for us, we are working with our Office of International Programs to get our clinical residency approved for the visa. So right now the status is uncertain, so I can't say for sure if you would be able to complete any of the three programs as an international student at this time.
As I say, Marley, I just saw your question. Do you find it difficult to market yourself and the DCLS to hospitals and corporations? If you're set in what you want to do, you will, for me, it wasn't a question of how am I going to market myself? It's I'm going to market myself. I'm going to have the conversations and I'm going to make what a DCLS is known. So even before I started my DCLS program with Rutgers, I was having conversations with my medical director about what a DCLS is and would they be receptive to having a DCLS on staff at our hospital, because you don't want to be going to your medical director, as you're finishing your program and getting ready for a clinical site, and then all of a sudden have them say, no, this isn't something we would want here, and get that negative pushback. So it's a matter of, I always found that pointing out the positives and speaking to your audience is appropriate. So I knew that my pathology chair was really into utilization and he wanted to start a utilization committee at our laboratory and with our hospital. And I'm like, okay, well, if you want to start the utilization committee, once I'm in my DCLS program, I can chair that. He's like, you can chair that. I'm like, yeah, that's what part of my training as a DCLS does. I am trained in clinical utilization and how to appropriately utilize the clinical laboratory in healthcare practice. So all of a sudden that's like, oh, this is something I want to start. And now I have someone other than myself to lead it. So making sure that you're speaking to your audience and appropriately marketing the DCLS where you are is the biggest, I think, push for it. And there's a lot of good reception that I have had to interprofessional teams. I have good friends on the internal medicine procedural team. I have good friends in hematology oncology, as Dr. Davenport can probably attest to. She had good friends with, surgery and other people before she even started her DCLS. And it's just like, okay, let me show you how I can help you now that I have my doctorate, or now that I'm getting my doctorate. So it's, again, making those friends in high places in the hospital before you even start, that will help you push to get this at your facility.
Now, it's a little bit of a catch-22 with how we're marketing ourselves and how we're received. Because there are not so many of us yet, it's hard to market ourselves and show all the good we're doing. which is why we need to publish. Make sure people know what we're doing, how we're saving them money, what benefits we bring to the table. As we have more people in the field, we can demand more of a presence at the table, if you will. At my facility, I'm well received right now. Everyone is very happy to have me on the committees and doing the things. However, if I went to another hospital, would I be as well received? Maybe not, because they don't know what I can do. So I think that plays a large role in it. Regina, how do you think it was for you?
Having solid support from one of the pathologists was really helpful. So she happens to be the chair of the clinical laboratories, and so she was able to open a lot of doors for me. So having at least one support person, and the higher ranking, the better. And then I totally agree. So once you kind of prove your worth and have some real data behind what you're doing and what you can do for the institution, that you can carry that wherever. So you can carry that through the institution itself and say, this is what I can do. Please fund money to help me do more. Or you can bring it to another hospital and say, this is what I've done. And this is what I can do for you. So.
And within the VA, there is no doctorate level yet for clinical laboratory scientists. So they kind of have to like make up a position at this point for the DCLS. They are working on revising the structure. So there is a doctoral level like they have for pharmacists. So it'll be on the same pay scale as pharmacists. So that'll be good once it gets there. How long did it take me to complete my DCLS? Well, I went the long route. And I did my master's because there was no DCLS when I first started. And I finished my master's. I took a year off. I had twin babies and waited about another 6 months. And then I started doing coursework again to finish the doctorate because that was now available. And so all in all, if you add up all my years, it was probably like 8 years. But if I had just like done it, not part-time, not taking years off, etc., it probably would have been about 3.5, 4. And this is why working full-time, I should say.
I had the same experience. So basically I went part-time most of the way as well. And it allowed me to kind of stay in the lab and work full-time, actually gain some experience. It was very helpful in the program itself. And then make those connections that I needed to make as far as establishing a clinical site and having their support.
Yeah, I just say most DCLS programs are built to be run part-time, and they're meant for the full-time working professional. Some people do choose to, work part-time and do the DCLS coursework full-time. And for them, it takes about 3.5 to 4 years to complete the degree. I did not take a master's degree. I dove straight into the DCLS after 3 years of on the bench work, because at the time I applied, it was 3 years of bench experience. Now it's been brought down to 2. But when I applied, my graduation date is 2024. So it's a 5-year program for me doing it part-time. And that's Rutgers requires your last year, your clinical year, be full-time coursework. So it's 4 years of part-time didactic and 1 year full-time clinical residency for me.
Julie. Oh,
you can go.
Go ahead.
Right, you want to finish on that? Yeah.
I would say, Julia, I saw a question that you just put in the chat. And the question is, which doctorate is more valuable, PhD with clinical rotation or DCLS? Well, I think we're a really biased panel right now, and we're going to say DCLS because that's what we all just went through. But yeah, so however, there is definitely merit to a PhD with clinical rotations because our clinical chemist specializes in GC, mass spec, LCMS, and does toxicology. And so most of her focus is on toxicology. I have little toxicology experience. I learned how to do it on the bench. I can, work up patients, but I have not kept up to the same level that she has. I don't know all of the drug classes as well as she does. So I defer to her as more of a specialist in that area, having her PhD with the clinical rotation background.
Yeah, and I can attest to that. We have 2 clinical microbiologists at my hospital where they have their PhDs in microbiology and then certification to be a medical lab director in microbiology. I will openly admit microbiology is not my strong suit, neither is molecular, but you can guarantee that they will be my resource experts when I am rotating, doing clinical rotations, because they know the field and they are up to date in the field even more so than I could ever be. So it depends on exactly kind of where you want to go with it. If you want to be a clinical practitioner and you want to do a lot more of the utilization work and a lot more of the research work and the patient care side of it, then the DCLS is the way to go. If you're looking for more of a lab directorship role and being a clinical, not clinical, but like a section director of like clinical chemistry or clinical microbiology, then the PhD with the clinical rotation is more where you want to go with your degree.
Yeah, I think what Katie just said is the most important. Think about what you want to do. What is your goal? What is your ambition? And then that will help you to decide which degree is really for you.
As I say, Renee, there's another question from YouTube that I think as a program director that you would be really apt to answering. How many years of experience do you recommend from a new MLS to graduate before applying to a DCLS program?
Yeah, that's a question that we talk about all the time, and we debated about it in terms of how long do you need to be in the field, so to speak, before you pursue a doctoral degree. As you said, we started with that kind of that 5-year mark was the original, and then we brought it down to 3, and now we've brought it down to 2. We don't have any evidence at this point. There's not enough graduates to really say 2 years really works, or 3 years really works, or 5 years really works. The more experience that you have, the more experience you have to draw from. We have argued that being closer to your MLS level training might actually be beneficial because you have all that working theoretical knowledge of subjects that we tend to let go of if we don't work in them, like microbiology or blood bank, or if you're not a clinical chemist, maybe you don't think about clinical chemistry on a daily basis. So those components can get lost in the shuffle. As programs, we do have at least what we call at KUMC, like boot camp components of our advanced courses to try to bring you back up to speed on all that theory that you've left behind. But there can be a really large learning curve when you're in those advanced classes, relearning all that MLS theory, because it's all built on that MLS theory. That's why you have to have the MLS certification, and why attending a NACLS accredited MLS program is so important is because we know then you have this base theoretical knowledge and you can advance from that. For those of you who've gone through the DCLS program, what do you think about experience? What level of experience do you think would be beneficial before starting a DCLS program?
So I think that you need to have a few years under your belt. And then, of course, this is going to be at the beginning of your coursework. But think about the fact that you cannot be a supervisor until you've had 5 years under your belt. So I think having at least 5 years before you are practicing DCLS is very appropriate, because you need to have a lot of that knowledge. Working as on the bench, though, I think adds a lot, because you'll have the ability to tell the providers more about the test and how they're run and what things get in the way, and you'll understand a lot of that sort of testing. So kind of like Katie was talking about earlier with, I told them, like, this is how I do the test. And then they were like, oh, that opens up a whole new window. So I think there's pros and cons to both on how long you've been on the bench. And I think it also probably depends on the person. Because some people hold on to that, like, minutia that you learn in MLS very well, and others don't, and had to relearn it. I remember getting to my molecular course and thinking, I don't remember any of this stuff. Did I learn this? So yeah, I think either way, but a couple years for sure on the bench before you start your coursework up again.
I would agree. And I would just add to that, that it also depends on the type of work experience that you're being offered at wherever you're working, wherever your first job is. Because some institutions, they really support growth and they have you, train you on a broad range of things in the laboratory to get you exposed to new stuff. Whereas other laboratories might work more like factories where you only do like small sections of the lab work. So it's all very dependent. The broader, the better, and the more exposure that you can get to like all components of lab work is ideal.
Yeah, I agree. And I actually think if you have, time to, maybe, get in the field and maybe move up into like technical specialist or like lead tech or supervisor positions, that's also very helpful because there is some management experience that comes involved with the DCLS and, knowing how to, have a budget and work with other techs and work with other people and have that, managerial role that's very helpful. I was just a bench tech when I started and I got promoted. I'm like, oh, there's all this now that I learned through my DCLS management program that now I can actually apply. So having some managerial experience, I think also, or some lead tech experience also really helps having that under your belt. So this degree was originally built, in mind with having, the seasoned techs who have been in the trenches for a long period of time applying to this DCLS program. And a lot of younger techs are applying to it because it's new and it's a great way to kind of like get your name out about the laboratory and be passionate about it. But having some experience under your belt, I feel is very helpful.
I would also say if you're considering it and you're newly minted MLS, talk with your supervisor, talk with your lab director, see where they sit with the DCLS. A lot of places are looking for retention opportunities and want to make sure you don't leave the laboratory. They might consider helping with tuition reimbursement, or they might be interested in grooming you for a DCLS position in your hospital enterprise. It's always good to have those open lines of communication.
So we have a question from Sharon Reyes. She says, do you think experience as a traveling MLS as opposed to experience as a full-time employee can affect applying to a DCLS program?
Cheyenne, I'm not sure what you mean by affect applying. Do you mean would it disqualify you from applying or prevent you from being competitive?
Cheyenne, I typed a little bit in there, but I think it depends on if you can just show that, you've had good work practice. This has been your job to travel and not just like stay at one place. But I don't think it will prevent you as being competitive if you can just like exhibit that, it's also giving you strengths by, I learned many LIS systems. I've seen how many labs work. I know what might be better or worse in practice. So I think you could use it as an advantage actually too.
I agree with that, Lindsay. I think having that extra experience of different labs, different algorithms, different ways of doing business in the laboratory would be beneficial. It's really how you market yourself in the interview and on your application that's going to impact whether that's going to be perceived as a disadvantage or as an advantage. I would say make sure if you're traveling to try to get involved in the institutions that you're traveling to, if you can. I know there's a lot of restrictions on traveling techs, but offer to, if you're on a contract for 12 weeks or longer, offer to be part of a project and see if you can get some of that project management experience that you could really put on your CV and display as good qualities towards becoming a DCLS.
Let's see, this one's for Regina and Dr. Davenport. Do you know what the return investment is? What is your current salary? I'm going to say range because I know some of you guys have contracts where you can't disclose your current salary, but do you find that there's a good return on your investment?
So the VA actually has a program where they give you up to X amount of dollars per year for coursework. So our VA for a while was like $3,000 a year towards any additional education that you were taking. They just raised it to $5,000 after I was done, of course. And then, so that really helped pay down while I was going, and I was going part-time. And then when I finally finish, I don't have too much in the way of loans, but there's also ASCLS scholarships, AMTF scholarships. There's lots of scholarships out there. And the base level is kind of on par with PharmD. For the VA, that's a GS 15. So it's public knowledge. I can share that. That's not what job I have right now. So mine's still secret. But we're trying to prove that, there is a worth. A new pathologist usually starts in like the 180s range. And some of our PhD clinical chemists are between like 130 and 150. So I would like to think that with this advanced degree, most people should be on par with that subset of newer professionals in the field. So, and it is more than an MLS. So, and think about how much those providers have to pay as well. So the return on investment, I think in the end is going to be okay. Obviously, if you don't work at all or don't get any support, it would take a little bit longer.
Thank you, Dr. Davenport-Landry. I think a lot of people probably wanted to know that. I have one question about the programs and how they dive deeper into the sciences, and as well as the hospital management side.
The question, I'm sorry, I was looking through the chat to see what the question was about.
This is not a chat question.
Can you repeat it a little bit? I missed the last part.
Okay, so this is for, as you guys' program, as far as your coursework goes, how much does it dive deeper into the sciences as opposed to just your normal 2-year and 4-year programs, MLS program?
So this is our program is kind of broken out into the core curriculum and to the residency curriculum. In the core curriculum, you take about 20 credit hours of advanced clinical laboratory science classes. So like molecular diagnostics, clinical chemistry, hematology, immunology and transplant, microbiology, transfusion services, advanced laboratory operations. Then we have about 11 credits of advanced health science, which is learning about the healthcare system, epidemiology, pathophys, pharmacology. Then we have about 9 credits in clinical correlation and evidence-based practice. And so learning how to correlate that all together, learning how to do that evidence-based practice that's so important to make sure that we're doing the best patient care possible. And then we have research methods, because we still do research. So you have to learn about research methods, quantitative versus qualitative. You have to take biostatistics and, of course, ethics behind proper research methods. And then at KUMC, we have interprofessional education and practice, where you learn about interprofessional education theory, how to work in a collaborative practice. And then we have a healthcare education course, so you can learn how to translate this for more less trained individuals. So being able to communicate laboratory information to a nurse who is an expert in their field, but not in ours. So you have to talk in a different language when you were communicating, even within the healthcare system. And we learn about that in our healthcare education course. And then we have the residency curriculum, which is your capstone research project, all your residency hours. And then you have advanced topics where you learn about additional topics that might have been missed in that core curriculum. I don't know if that exactly answers your question, but as far as like basic science, there's not a lot of basic science information that you're learning in the DCLS program. And I know that all 3 programs are similarly structured. You might see some nuanced differences between the 3, but they're essentially using this sort of same basic pattern.
That was a perfect answer. just wanted to know how farther into depth people or the programs go. There are a few more questions in the chat. We're probably going to wind down to maybe the last two here. So we have one about, Kathryn answered one about the class sizes. If you guys want to expand on that, or we can go into.
I'll just say that Regina and I were the only two in our cohort that year, but it has become much, much more competitive. And I know that two of the schools interviewed over 40 people last year, and they accepted between 10 and 12. So people are wanting to get this degree and join the community of DCLSs, but don't be discouraged if you don't get in right away and apply the next year, because the more interest there is, the more schools we can promote and see and get out there, and then we can also allow more people into the programs.
I was gonna say, I'm one of two in my cohort as well. There are other people who have joined our cohort because they came in with master's credits or other credits that put them on par with our graduation year. But when I interviewed, I think Rutgers my year interviewed, they had at least 20 applicants. Half of them didn't meet the requirements, so they were automatically excluded. I think they interviewed 12 and they offered 4 and only 2 accepted. So it is a competitive program. That's why they have the requirements for a GPA. And again, if you feel like you aren't, this is all about selling yourself. If you don't feel like you are good in an interview, which I know I am not, I actually did practice interviews with some managers before I did my DCLS interview, because I can guarantee you I've stuck my foot in my mouth during an interview. So, and I did not want to do that with my DCLS interviews. So it's finding ways to make sure that if this is something that you genuinely want to, pursue, that you take the steps you need to make sure that you do it.
And remember that the DCLS is a new profession. It's brand new. The first graduate from a DCLS program was just in 2019. Like, we've come a long way in the last few years with programs and how many students. I think for the upcoming fall of 2022, all 3 programs are looking to take between 8 and 10 students. That's about where everybody is sitting right now. As far as graduates, there are 25 graduates from UTMB, and I believe there's 5 graduates from Rutgers. I think UTMB might have a couple more coming out here in December, because December is a graduation month for them. And so we still don't have a lot of people practicing as DCLS yet. Those numbers are increasing and increasing. And yes, all of those graduates do have jobs. They're working in different areas and different fields, from basic science research to directing clinical laboratories and consultation and education. There's a lot of avenues that you can take the DCLS, and there's a DCLS student or DCLS graduate doing each of those different ones. And some are doing more than one. Some are doing clinical consultation and education. So it's a kind of build your own story. That's the unique thing about being part of a new profession. We're building it as we go.
I did want to answer Erin Uhelski's question, which was about meeting a little bit of resistance from her lab director about the DCLS, and asking how many hospitals have actually taken on the DCLS. I don't know how many exact hospitals have, but I know not enough. Even hospitals who are interested in the DCLS are having a hard time funding a new position for a DCLS. So a lot of DCLS people who I've been in contact with, or at least some of them, are taking on roles that have opened up for like quality or something like that. Something that necessarily isn't designed specifically for a DCLS. So if you're looking for a specific DCLS role, that's still a challenge right now, because they have to like build a role. They have to say what that person is going to be doing, how they fit in with the structure of everything else, and how are they going to fund it? Where does that money come from? So it's difficult right now.
Okay, so Thank you, Regina. I think we have enough time for one other question. I'm looking through the chat, seeing if anything wasn't explained or not. I would say you guys just kind of touched on what is there to expect from DCLS in the future, and as far as advocating for it. So we could go with, does anybody have another question they want to, or anything, any more information they want to continue with?
I think we can just impart on you that, continue to talk about this. Make sure that you spread the word that this is a thing. The more we talk about it, the more people in our own profession will know what we're doing. I mean, my grandpa still does think that I just draw blood. And my little brother thinks that I'm a doctor that sees patients on the floor, even though I advocate for myself all the time. But we just have to keep talking about what we do and know that, there's this new thing out there, and it's the Doctorate of Clinical Laboratory Science. And this is what we do. This is how we help. So if we keep doing that, then I think we'll see growth and also provide a better voice for our profession overall, not just as DCLS, but as medical laboratory scientists and as clinical laboratory people in general.
Thank you, Dr. Davenport-Landry. Renee, Regina, any guys want to say anything, add anything else? Kathryn, no?
Sorry, you caught me doing one too many things. I was typing and wasn't paying
Oh,
attention.
you're fine. You're fine.
So final thoughts about the DCLS. I just bring it back to the DCLS really is about the right test for the right patient at the right time. And if that is what you're passionate about, that is motivation enough to pursue a DCLS. That is the take-home message. There are so many people getting the inappropriate tests or the right test at the wrong time and not getting the health care that they need to get better. We're looking at hitting that, the triple aim, or what's now the quadruple aim, lowering the cost of healthcare, making better and happier providers, providing better patient care. That is really the heart of what the DCLS is doing.
I was gonna say, I'll agree with that. And then I'll expand as well. One of the big things that I want to do, and that was kind of a draw, is that, there's a lot of education portion in being a DCLS. You're doing a lot of provider education as well, if that is the route that you choose to go with your DCLS. And that is something I genuinely enjoy doing. I had a conversation actually with a provider who was helping me on a presentation for one of my classes. And I was telling him about the DCLS and what I wanted to do. And I was telling him how I thought it was inappropriate to order a CBC with DIF on a new acute leukemic every 4 hours, which is something that I have experienced at my hospital. And he said, well, sometimes it's just easier to reorder it instead of looking for it. And I'm like, I pointed my finger at him, which was not a smart idea because he is one of the chiefs in that department. But I said, that is the attitude I'm trying to change. And he kind of sat back and just like, oh, okay. And you want to have that educational portions, and you're going to be a trailblazer in this field. Anybody who goes and starts this degree program within the next couple of years will be one of the first 100 to 200 in the country. And you need to be able to kind of stand up for yourself and, blaze a trail for the DCLS. So it's an interesting time to join the program.
My takeaway is going to be just keep looking for those gaps that you can fill as a DCLS and wherever you work, because that's going to be unique for each one of us. And if you know that there's something that needs to be fulfilled that's not being fulfilled by anyone currently, then that's your reason to keep going with the DCLS. And then you really have to just kind of have confidence in yourself, because you will be met with resistance, whether it's from outside your institution, inside even ASCLS. I feel like I had a little bit of resistance within the CLS community, just because they didn't know what DCLS was. And so they it was hard for them to kind of support it because they had nothing to base it off of. But believe in yourself, try to find somebody else who also believes in that vision, and that'll kind of keep you going. But there are so many gaps to be filled. And like I said, if you can find what those are at your institution, that's where you're going to find your success.
Thank you so much, Regina, Kathryn, Dr. Davenport-Landry, and Renee. We really appreciate you guys sharing your information and your experiences with us. If you guys don't have anything else to say, I thought you guys did an amazing job. I don't know if you guys can hear me. It says connection is unstable, but you guys have some amazing answers. We truly, truly do appreciate you and hope that people can advocate for DCLS and CLS from the things you gave us.
Thank you, everyone.
Yeah, thanks.
Thank you.
Thank you.